This presentation is about donating eggs for the use of other individuals. The most common reason women need donor oocytes is that they are in their 40s and their ovaries have stopped making enough oocytes of good quality. The menopause commonly happens around the age of 50, but the ovaries usually stop producing sufficient good quality oocytes by the age of 42. Indeed, in some women, the ovaries stop producing oocytes at a much earlier age, even as young as the mid-20s, for no obvious reason. This is known as premature ovarian failure. In other women, the ovaries may be removed for medical reasons, and cancer treatment may be affected by cysts, endometriosis, etc. Sometimes a woman does not have functional ovaries right from birth, e.g. Turner syndrome. Oocyte donation is a precious act because treatment using donor oocytes provides these women with their only chance to become pregnant and carry a child to term. Donor oocyte treatments carry risks for patients and are tightly regulated by the Human Fertilization and Embryology Authority, the national regulator of the fertility treatment sector in the UK. Potential oocyte donors should be between 21 and 35 years old and should ideally have completed their families. They will complete a detailed health questionnaire and consultation with a doctor, including a physical examination including pelvic scan to initially assess suitability. Blood samples will be taken to check for diseases which would prevent the person acting as a donor. These screening tests will rule out mainly viral infections such as hepatitis B and C and HIV 1 and 2, and cytomegalovirus, as well as bacteria infections like syphilis, gonorrhea, and chlamydia. Donors must also undergo karyotype test to check the right number of chromosomes and for specific genetic conditions prevalent in their ethnic group. For example, cystic fibrosis in Caucasians, sickle cell anemia in Afro-Caribbeans, and so on. This ensures the donors are medically and genetically healthy. Finally, potential oocyte donors are tested for anti-Mullerian hormone levels, which are indicative of ovarian reserve. Ideally, our egg donors have a good level of above 15 polo. If during donor assessment we find anything which prevents a potential donor from donating, we will inform them of our decision. We will explain why we have made it and, if necessary, refer them to a suitable clinic for review and any treatment necessary. Finally, 3 months after oocyte collection and freezing, the donor must attend the clinic for final post-quarantine blood samples, which are again tested for transmissible diseases. Only if the blood tests are clear, the stored oocytes can be released for use in treatment. All these activities significantly reduce the risk that the donor passes on any serious diseases or medical conditions to a recipient and or any child conceived through treatment using their eggs. We also ask that potential oocyte donors are open and honest in their answers to our questions, so our assessments are effective. Indeed, if an oocyte donor is deliberately inaccurate when answering our questions or fails to disclose essential information, and this results in a child being born with an inherited condition or disability, the oocyte donor may be liable to be sued for damages. Let's now go over the actual process of developing, collecting, and freezing oocytes. If accepted, an oocyte donor complete consent forms to record their consent to undergo a cycle of ovarian stimulation and oocyte recovery, and for their oocytes to be stored and used in the treatment of others to produce a specific number of families. They will also complete a donor information form and a donor personal statement, which are submitted to the HIFE register and are made available in anonymized form to persons considering being treated with the donor's oocytes. Once consent is provided, the oocyte donor can start a cycle of ovarian stimulation leading to oocyte collection. The donor is also advised to refrain from sexual activity or use barrier methods of contraception from the start of the menstrual period before ovarian stimulation and oocyte collection are planned. The egg donation treatment cycle begins on the first day of the donor's menstrual period. Ovarian stimulation involves self-administered daily injections to stimulate the ovaries and ultrasound scanning at the clinic to monitor ovarian stimulation. When the ovarian follicles are at the correct size, that is about 18 to 20 cm in diameter, the trigger injection is administered, which matures the eggs, and then oocyte collection is undertaken at the clinic 36 hours later. This happens under sedation. A thin needle attached to the vaginal probe of the ultrasound scanner is inserted through the donor's vaginal wall into each ovary to harvest follicular fluid containing oocytes. The oocyte collection process lasts about 20-30 minutes and generally produces only mild moderate discomfort, the donor being able to return home 1-2 hours later. The embryologist then processes the mature oocytes to freeze them in a process called vitrification. The mature oocytes are then stored in liquid nitrogen until needed for use in treatment. The quality of such frozen oocytes should not deteriorate over time. Are there any side effects or risks? As with any medical procedure, treatment during oocyte donation has possible side effects and risks, varying from patient to patient. Sometimes there is skin irritation at the injection site, or sometimes abdominal bloating, headaches, breast tenderness, and nausea. Oocyte collection is a relatively simple operative procedure that carries few risks. Patients may experience pain or abdominal cramping after oocyte collection, similar to bad period pains. There is a small risk of infection, but we reduce this by giving prophylactic antibiotics when needed. Stimulation of the ovaries can be associated with ovarian hyperstimulation syndrome, which leads to abdominal bloating, pain and discomfort, along with nausea and mild to moderate discomfort. Severe ovarian hyperstimulation syndrome can lead to additional symptoms including dehydration, reduced urine output, difficulty in breathing, reduced blood pressure, and fluid retention in the lungs and around the heart. This is serious and may even need hospital admission and careful monitoring. Thankfully, this happens very rarely, but if untreated, is a potentially fatal condition. So donors must contact Acorn Fertility or attend their local hospital emergency department if they feel very unwell. We identify women more likely to experience ovarian hyperstimulation syndrome and take various measures to reduce the risk. Mild to moderate ovarian hyperstimulation syndrome can be managed with pain medications and will usually resolve on its own accord within a week or so. All medical tests carry a very small but finite risk of failure, and thus a donor is never 100% safe to use. It is also possible that our assessment may not detect an undiagnosed genetic illness in a donor, which may be expressed in a child conceived using the oocytes in a more severe form. It is also possible that a donor may be a carrier of a recessive genetic mutation which she may be unaware of. The same may be true with the recipient's partner. In such a situation, there may be a child born with a genetic abnormality. Such diagnosis in a patient conceived through a treatment occurs some months or years after a donor's procurement process. So you must make sure to advise Acorn Fertility of future changes to your contact details. That way, we can arrange a clinical review and if necessary do more tests, as there may be implications to the child born as well as to the egg donor. Donors also must inform their recruiting center of any medical information that may come to light after their donation, that may have health implications for any woman who receives treatment with their oocytes or for any child born as a result of such treatment.